So, adult-onset Still's disease. Consider this clinical case, which is pretty typical. You have a 29-year-old man. He developed a fever lasting for more than 5 weeks, preceded by a sore throat and anorexia and weight loss. His physician has seen him and he started multiple lines of broad-spectrum antibiotics, but the fever continued. At a certain point, he developed a polyarthritis, shoulder, wrists, ankles, and knees, and polylymphadenopathy. He developed a probable allergy, skin rash, to levofloxacin, one of the antibiotics he had recently taken. All the cultural tests were negative, including a cultural examination of the synovial liquid. All tests for common pathogens were negative, including HIV, EBV, CMV, HBV, ACV, and Toxoplasma, Bartonella, and Brucella. The quantiferon test for tuberculosis was negative. NAA were negative, rheumatoid factor was negative, CRP, C3, and C4 were moderately high, possibly because of inflammation. At this point, the physician made some further radiological investigations, checking for endocarditis, but the transesophageal echocardiography was negative. A CT scan confirmed splenomegaly and hepatomegaly. At this point, not biopsy and bone marrow biopsy were performed, but they were not informative. Still, the patient was sick. So, fever of unknown origin is a very important clinical condition. This is the tree of fever from Francesco Torti, an Italian physician. Tried to classify all the known fevers in a sort of hierarchical pattern. When facing a fever of unknown origin, there are a certain number of conditions you should consider for differential diagnosis: infections, malignancies, and systemic diseases. And now I would like you to bring your attention on a systemic disease, which is adult-onset Still's disease. Adult-onset Still's disease is a rare disease found worldwide, with an estimated incidence of 0.22 and 0.34 per 10,000 subjects. It typically affects young adults aged 16 to 35 years. It's a febrile disorder of unknown etiology, characterized by typical spiking fever with an evanescent rash, arthritis or arthralgias, and multi-organ involvement. It's a rare disease, but among the patients with fever of unknown origin, about 4% will develop adult-onset Still's disease. Also consider that if you put together all the patients with traumatic disease, 2% of those who develop fever have adult-onset Still's disease. It's not an easy diagnosis because it's a diagnosis of exclusion. Generally speaking, adult-onset Still's disease is characterized by typical spiking fever, elevated ESR and PCR, neutrophilic leukocytosis, which makes you think of an ongoing infection, but this is not the case, an evanescent rash, arthritis or arthralgias, markers of autoimmunity such as NAA and the rheumatoid factor are negative in 90% of patients, so the markers of autoimmunity are negative usually. We have fever. It generally exceeds 39 degrees and is transient, lasting typically less than 4 hours. It is mostly quotidian and or double quotidian in pattern, with the highest temperatures in the afternoon or early evening. Rash is evanescent, only seen in the adult acute phase. It has a typical salmon pink color, which is what distinguishes it from an allergic rash. Furthermore, if you make a skin biopsy, what you find is perivascular inflammation with neutrophils, lymphocytes, and histiocytes in the superficial layers of the dermis. In arthritis, the pattern of arthritis is typically symmetric. When you have a patient with adult-onset Still's disease and there is arthritis, you have two main possibilities. We have intermittent arthritis, which is strictly associated to the systemic inflammation, and once the systemic inflammation goes away, also the arthritis disappears. You can have also persistent erosive arthritis, in which the arthritic event starts from the wrist. you start having an inflammatory reaction around the capitate bone of the hand, which is just at the basis of the third finger. At X-rays, this presents with fusion of all the bones that surround the capitate, while usually the wrist itself is spared. This is different from rheumatoid arthritis, in which you have erosion starting from the ulnar styloid. Laboratory findings are liver abnormalities, predominantly hepatomegaly and abnormalities in liver biochemistry, with increases in LDH, transaminases, and bilirubin. We have elevation of ferritin. Consider that under the influence of IL-6, macrophages increase their synthesis of ferritin. They also secrete ferritin, so ferritin behaves as an acute phase reactant. When ferritin is increased, also CRP is increased because they are both IL-6 dependent. Remember that in acute-onset Still's disease patients, ferritin is increased much more than you would expect in an inflammatory disease. In acute-onset Still's disease, ferritin levels are ranging from 4,000 nanograms per milliliter to 30,000 nanograms per milliliter, which is extremely high. You also have to check for the levels of glycosylated ferritin. In normal conditions, glycosylation of ferritin is usually 50 to 80%, while in these patients ferritin is high while its glycosylation is low, less than 20%. Unfortunately, not all labs check for glycosylated ferritin, but it would be good to check it because high ferritin levels are not specific, while apparently the patients keep having a poorly glycosylated ferritin even when the acute inflammation has resolved. As in all diseases in which diagnosis is complex, you have sets of diagnostic criteria. For you, they are just useful to memorize the most typical features of the disease. So we have these Yamaguchi criteria. We have the major ones, which are fever at least 39 degrees lasting at least 1 week, arthralgias or arthritis lasting 2 weeks or longer, a non-pruritic macular or maculopapular skin rash that is salmon-colored in appearance and usually found over the trunk or extremities during febrile episodes, leukocytosis with at least 80% granulocytes, and the minor criteria are sore throat, lymphadenopathy, hepatomegaly or splenomegaly, abnormal liver function studies, particularly elevation in aspartate and alanine aminotransferase and lactate dehydrogenase concentrations, and a negative test for antinuclear antibody and rheumatoid factor. For diagnosis, we need at least 5 criteria, of which at least 2 major criteria. Once you have these suggestive features, you should exclude several other events, such as lymphoproliferative events and other conditions associated with too high levels of ferritin, such as macrophage activation syndrome. Laboratory tests are basically negative, beside the presence of elevated ferritin and liver enzymes. You can also look for a destructive evolution at X-rays. The clinical course of adult-onset Still's disease falls into 3 patterns, each affecting about 1/3 of patients. We have the self-limited or monocyclic pattern, which is characterized by an important inflammatory onset with systemic symptoms, but then the disease disappears. Most patients achieve remission within 1 year from the first and only disease episode. Then, second pattern is the patient with the intermittent or polycyclic systemic pattern, in which you have relapses, with or without articular symptomatology. There is a complete remission between the flares that may be years apart and tend to be milder than the initial episode. If you follow these patients long enough, the inflammatory events become milder and milder. Then, third pattern is the chronic articular pattern, associated to an important joint destruction, which can get complicated to deal with. Adult-onset Still's disease can be considered an autoinflammatory disease because it responds pretty well to anakinra, which is an agent that interferes with the IL-1 beta pathway. So it's a IL-1 receptor antagonist. Regarding pathogenesis, the idea is that there is an initial event, such as an infection, that could select patients that have an inflammasome particularly prone to react. As a result, you will start making IL-1 beta and IL-18. This will lead to an amplification of Th1 cells. These patients are at risk for the development of macrophage activation syndrome because you activate NK cells and Th1 cells, but in parallel these cells are not quite good at their cytotoxic action and thus are unable to kill the antigen-presenting cells, which is possibly quite a relevant step to terminate an immune response. If you start making a lot of cells then that are not able to kill the antigen-presenting cells, this can create troubles. In the meantime, there is activation of Th17 that recruits neutrophils. Again, this reflects on the fact that you have further generation of IL-18 and IL-1 beta. IL-1 beta is able to do virtually everything. If you increase IL-1 beta, you can somehow replicate most of the clinical features that we see in this patient. We have fever. In fact, IL-1 beta is a pyrogenic agent. We have leukocytosis and increase in platelet counts. We have an increase in transaminases. We have arthritis and cartilage erosions and amyloidosis. Complications of adult-onset still's disease. There are 5 complications: DIC, thrombotic thrombocytopenic purpura, diffuse alveolar damage, pulmonary arterial hypertension, and macrophage activation syndrome. So, mainly involving the pulmonary and the hematologic component system. Macrophage activation syndrome starts in a way that is pretty similar to the adult-onset still's disease, but you have a cytokine storm that is more important, and you have a huge expansion and activation of T lymphocytes. In the meanwhile, because of all the cytokines that T cells produce, you have hyperactivation of macrophages and a hemophagocytic picture. This results on one hand in pancytopenia due to the fact that there is so much phagocytosis going on that the other series of blood cells are depressed, leading to this important systemic inflammatory syndrome. Consider that it is a syndrome with a great mortality. Macrophage activation syndrome is a typical complication of adult-onset still's disease. So if there is a suspicion of a relapse of adult-onset still's disease, it might not be a relapse but a macrophage activation syndrome that is starting. Macrophage activation syndrome is one of the worst complications of acute-onset still's disease. Treatment. Adult-onset still's disease patients respond to corticosteroids. If steroids are not sufficient, you can give IL-1 beta receptor antagonists.